Welcome everyone. I am Pam Fury, System Manager for CDI. This session is focused on documentation of diagnosis related to abnormal labs. As a reminder, much of the content presented can also be found on your tip sheet pocket guide and/or posters placed in the physician documentation areas. The objectives of this session are to identify those abnormal lab values that are diagnoses which occur frequently and will impact patient acuity. We will review the clinical criteria and the evidence required to support the abnormal lab diagnosis. And just as a reminder, some of these diagnoses are considered or very important comorbidities or major comorbidities that do impact the patient acuity. The most common abnormal labs that impact the patient acuity are, and the ones we see most frequently are lactic acidosis, hyper or hyponatremia, pancytopenia, rhabdo, HIV, AIDS, and acute blood loss anemia. We'll go through each one of these individually and talk about the challenge, what we see, the type of patients we often see this abnormal lab found in, and then what the guidelines are, the clinical evidence guidelines for documenting this as a diagnosis. So we'll start with lactic acidosis. The challenge that we have here is it's pretty frequently a misdiagnosis and not documented. Patients will often have an elevated lactic acid without the diagnosis of lactic acidosis being documented. When do you see lactic acidosis? This is not new to you all, but just a friendly reminder. It often occurs with patients that are in ICU or CCU or SICU that are critically ill. It often occurs in a sepsis and or a shock patient. You can see it with acute renal failure. Patients that have poisoning or ETOH, you will see lactic acidosis, acute severe asthma, cardiac surgical patients. Some medications can also cause an increase in lactic acidosis, metformin and albuterol. You will see it, though, in a normal situation, which could be a normal occurrence in a healthy athlete during exercise. And sometimes you can write a diagnosis and say expected. So you could have lactic acidosis expected due to, and in this situation, it's an expected occurrence. And it's important to remember to distinguish the diagnosis of lactic acidosis from respiratory acidosis and metabolic acidosis. And the guidelines are a blood lactate over 2 and or an arterial blood pH of less than 7.35. The next abnormal lab as a significant comorbid diagnosis is either hyponatremia or hypernatremia. Again, it's often missed as a diagnosis that's documented, and most people don't document it until it's severe. And just so you know that it is present in SIADH. So the sodium guidelines are the following. So the normal range, the typical normal range for sodium is 135 to 145. There is a diagnosis of hyponatremia, but considered mild. So mild hyponatremia is anything less than 135. And it's something that you have to monitor, right? So as long as it's being monitored or a patient's receiving IV fluids, we have a treatment in place with clinical evidence and indicators. You can write the actual diagnosis. Severe hyponatremia is anything less than 125, and hypernatremia is anything greater than 145. The guidelines for SIADH are a plasma sodium less than 135 for hyponatremia, or a plasma osmolarity less than 280, or a urine osmolarity greater than 100, or a urine sodium greater than 30. And then clinically, the patient is even with their volume and their sodium levels in their volume. Pancytopenia. Pancytopenia, typically the clinical evidence and the clinical indicators are present, but it's very, very frequently actually a misdiagnosis to be documented. There's And the other challenge that we have is there's not a specification that says pancytopenia is secondary to, because typically pancytopenia occurs in conjunction either secondary to chemo or radiation or an underlying malignancy. So you often see it, sometimes it can be idiopathic. About 50% of the cases it occurs and the cause is unknown. Oftentimes that can be an autoimmune disease that the patient has that can cause pancytopenia. It often occurs in a viral infection, a drug reaction, an exposure to a toxin. Can also occur with liver failure and occurs with cancer patients with chemo or radiation. The clinical evidence to support the diagnosis of pancytopenia is if all of the following criteria are met. All three must be met. The WBCs need to be less than 4,000. The RBCs less than 4.2 in women or less than 4.7 in men, and the platelets less than 150,000. The next lab diagnosis, if you will, is rhabdo. And typically clinical indicators are present in rhabdo, but the diagnosis is just not documented in the medical record. One of the other challenges we see with rhabdo is there's really no specification of the type of rhabdo or the etiology. And there are, you can just have rhabdo or you can have a traumatic rhabdo. And most often we see rhabdo occur when a patient is, quote, found down and they've been down for an unspecified period of time. You see it in falls, also in crushing injuries, which you're all familiar with, and or burns, car accidents and trauma. And you also can find rhabdo in patients with substance abuse, lots of toxins. It can occur with taking some non-prescription drugs, and also statins can cause rhabdo. The clinical criteria, it's a triad of complaints typically when you have rhabdo. The evidence to be able to write the diagnosis, it's, the dark urine, the weakness, and the muscle pain. Frequently you can see the serum CK is about 5 times normal, and it can rise within 2 to 12 hours following the event that occurred to cause the rhabdo. You might also see the creatinine in the urine greater than 110 to 300, and you also will see some myoglobin in the urine. It's just typically present. Normal is low or non-detectable. You don't usually see any myoglobin in the urine. HIV and AIDS. The state of California poses an interesting challenge regarding HIV and AIDS. In the state of California, you are not allowed to document or code anything related to an HIV status. The only time you're allowed to capture HIV status is if the patient has had or currently has a diagnosis of AIDS. So it's typically the diagnosis is missed and not documented even if clinical indicators are present. HIV can be diagnosed with or without an AIDS diagnosis. So it can be documented. It's just not allowed to be coded in a chart and end up at a payer site. The clinical criteria and evidence for prepared by the CDC is if the patient has ever had AIDS, they would have an AIDS defining condition in addition to a positive HIV. That's the clinical criteria and definition of AIDS. An AIDS defining condition, and those are all listed below. We'll go through a few of those in a moment, with a positive HIV. They have HIV if they have a CD4 count that's less than 200, and they can have that with or without an AIDS defining condition. And AIDS is also defined as stage 3 HIV. So if you've ever seen in the history of a patient coming in with stage 3 HIV, that is AIDS. And a lot of times you'll also see in the history of a patient that they're on heart treatment. So what are some of the AIDS defining conditions? There's many of them. I won't go through them all, but please refer to them. Bacterial infections, yeast infections, cervical cancers that are invasive, coccidio, that's disseminated or extrapulmonary, cryptococcus, that's extrapulmonary, cytomegalovirus, encephalopathy, some progressive multifocal leukoencephalopathy, herpes simplex, chronic ulcers, histoplasmosis, Kaposi's, lymphoma, salmonella, toxoplasmosis of the brain, and some wasting syndrome can also be due to AIDS. So these are all AIDS defining conditions. There are some hyperlinks here to get even more details than that. Okay, acute blood loss anemia. Um, the challenge is a patient can frequently have ABLA following a surgical procedure, and it is okay to document it as an expected occurrence. Just because it's expected does not mean it's not a proper diagnosis that needed monitoring, maintenance, and or treatment. So what you need to consider is that it often does occur with a surgical procedure and pretty frequently in ortho procedures. It often occurs with GI bleeds, whether they're acute or chronic, and it can occur with many OR procedures um, when there is an acute blood loss that is not unexpected. So you can document acute blood loss anemia expected or just acute blood loss anemia. So the guidelines for ABLA is a drop of hemoglobin of 1 to 2 or greater, a drop of a hematocrit, same thing, 1 to 2 or greater. You can have either one. Treatment via a transfusion. But some guidelines for transfusions, they differ by facilities, right? Some facilities might transfuse less than 8, others they wait till less than 7. You can still diagnose acute blood loss anemia and monitor the H&H without actually giving a transfusion. And or a patient could have development of symptoms of anemia that were not previously present. And those are primarily the abnormal labs that will change the acuity of a patient's score um, and are considered a comorbidity or a major comorbidity. I will tell you that in some patients, certain abnormal labs that I did not include in here, like hypercalcemia, um, that are not considered a comorbidity quite as much, but they are a diagnosis and need to be recognized even if they're continuing to be monitored. Will also increase the allowed length of stay for a patient when they're an inpatient. So just try and capture all the diagnosis. You might also ask, why is hyperkalemia or hypokalemia not included on here? For some reason, it is absolutely a recognized diagnosis that has major ramifications clinically and needs to be treated, but it's not captured as a significant major comorbidity. And so there are those that do not make sense to me, but can also change the allowed length of stay. So just try and be sure to capture all of them. And once again, I want to say thank you for being a valued member of our team and helping us capture all of the great treatment and diagnosis that you're doing for your patients.